I wanted to welcome everybody and thank you all for sharing a little bit of your very busy days with us this morning to talk about ASAM Continuum and ASAM co-triage. I'd like to thank those of you who are currently using ASAM standard-based tools and those of you who have asked us for this integration, and you're the reason, obviously, that we're all here today. We're fortunate to be joined by Dr. David Gosfried and our partners at the American Society of Addiction Medicine. To make the most of this opportunity and to hear and ask questions of our guests today, we'll spend most of our time talking about the ASAM Continuum and co-triage specifically. But please, if you'd like to have a one-on-one demonstration of how the integration works and feels, or to talk about pricing, please let me know in a chat here on the call or in a support ticket, and we'll set up some time to talk to you about getting these tools integrated for your clinic. We'll also at the end take some questions, and you can either raise your hand here on the webinar, or you can, and we'll put you off mute and you can ask your questions, or else you can type it out and we'll read it and you can have questions answered directly by the expert. Our guest is an addiction psychiatrist whose contributions have been recognized by Harvard Business School, the New York Times, and he's provided guidance to governments across the globe. And his research and tools are the reason that we're here, and what you'll be seeing. With that, I will turn it over to our guest.
All right, thank you so much. And my name again is David Gastfriend. I'm an addiction psychiatrist, and I'm the chief architect for the ASAM Continuum program, which now has several tools. We're going to focus on ASAM Continuum because that's sort of the granddaddy of this toolkit. So the Continuum system is a standardized approach that's guided by the computer to help the clinician or the interviewer conduct a structured interview, an organized, systematic, comprehensive interview to assess patients with substance use disorders and their co-occurring physical and mental health problems. So it's a comprehensive approach. It's essentially the full biopsychosocial. And I want to thank ClinicTracker for its vision and for being a leader in the field and investing in integrating this directly into your EHR system so that you sign on to your system and you get access to buttons to bring up Continuum within it. And that's the most convenient way to do this. So Continuum allows the clinical interviewer, the person who is doing intakes and follow-up assessments to determine if patients have various needs and also strengths. And it lets them conduct a comprehensive biopsychosocial assessment of the patient's risks and their needs. And it does this across all 6 of the ASAM criteria dimensions. And as you know, the ASAM criteria are required in Arizona, and they're actually endorsed by most of the states in the US. And that's because of the evidence base that when patients are assessed with this system and placed in treatment according to these recommendations, they have better initial engagement, better follow through, better retention over the next 3 months. They have better outcomes over the next 3 months. And they even have, in one study, less utilization of hospital bed days over the next year. So proper placement is incredibly important to the patient's health, to the patient getting into a recovery mode, and to costs for the system. So we want to use Continuum to determine the ASAM criteria level of care recommendation. And we're not using it in isolation. We're using it in context with the book, the ASAM criteria. So the book, the textbook, the ASAM criteria, gives you the background and the guidance for how to use the software properly. It explains the decision rules and the logic behind the ASAM model, which is now 30-something years old. So for 3 decades, we've been refining and perfecting this system. And the Continuum software actually takes every single decision rule in the adult admission criteria in this book. And for each decision rule, it figures out what information is needed to operate that decision rule. And then it uses algebraic, precise, quantitative information that you put in to calculate mathematically what is the best level of care to recommend for this patient. So this is how you get a comprehensive, complete informational experience. And the data gathering is consistent regardless of the patient, regardless of the provider, and even low-level training is sufficient with some experience using the interview to get a good level of care recommendation, a valid and cost-effective level of care recommendation. So that means, yes, your expert interviewers, people who have PhDs and master's degrees in social works, yes, they have more experience, they have more expertise. They'll get a little bit more detailed information, richer information. But even a novice social work student on the first day who's trained to use this assessment tool can get a very good level of care recommendation and will be in a fairly narrow range with the experts. So that's a remarkable thing, to raise the bottom of the standard of care for assessment and placement across the entire workforce of a treatment system. So we're going to be using the software to assess the level of care, determine priority needs. It actually generates a problem list, which is the beginning of the treatment plan. And it does this multidimensional assessment based on the ASAM criteria, using every single decision rule in the book. Then for each patient, it will assess their needs, their strengths, and it does this for the moment and also thinking a little bit beyond the moment, like what are the needs over the coming period of time, and it will determine the appropriate level of care with more information than seat of the pants, off the cuff, run of the mill, intuitive assessment is going to achieve. This is not an advertising claim. This is what the data show from multiple studies. There are about 30 papers in the scientific literature that have looked at this question and come to this determination. So the beauty of having this within ClinicTracker is that you can be in a single sign-on into ClinicTracker, press the button to run Continuum or co-triage, and have that come up, follow the questions, accurately determine the answers to each question, plunk them in one at a time, and at the end of the interview, which on average, once you're fully trained and through the learning curve, that can take about 60 minutes for the average patient. And then you get instantly reports that generate the level of care that should be recommended. And this includes specific instruments like the ASI, the Addiction Severity Index. The ASI is the most widely used research assessment in the world, and it generates severity subscale composite scores for alcohol and drug use, employment problems, legal problems, family social problems, and psychological problems. All of those scores are printed in the reports that Continuum generates. Very legible, very clean, even graphically. Continuum will also generate a complete assessment score for withdrawal needs for patients who have substances that they've been using that produce withdrawal, if they have withdrawal needs. And so they'll use the CIWA, the Clinical Institute Withdrawal Assessment for alcohol, the CINA, the Clinical Institute Narcotics Assessment for opioids. And if the patient has either of those categories of substance use, sedatives also for the alcohol assessment, it'll generate their score. And it'll tell you, how does that score fit within the range of possible scores? So it's a very comprehensive approach. Now, There is also a tool called the ASAM co-triage or continuum triage. And this again is a computer guided tool. This is a quick one. This is a 10-minute or less interview. It can even be done over the phone. And it's a provisional referral. So when patients call into a referral center and they say, you know, I need to go for treatment, often they get a referral and then they have to go to that treatment program. And then that treatment program interviews them and then finds out, yeah, we're not the right place for you. You need to go to, you know, a residential program, or you need to go to outpatient. And now the patient is discouraged and is prone to dropping out. So Los Angeles County, which is 11 million people, LA County Department of Health said, ASAM, could you construct a brief version of Continuum, like 10 minutes or less, that could even be done by a call center over the phone, that in 20 or 24 questions can figure out what's the likely best place to send this patient to then go get their full assessment. So co-triage is about 20 to 24 questions drawn directly from Continuum that assists the clinician to identify the broad categories of need, again, along all 6 of the ASAM criteria dimensions. You can't miss a dimension when you're using Continuum or co-triage. And then it directs the patient to a preliminary or provisional level of care where they should go to get the full Continuum intake. Now, is the patient going to then go to that place and say, oh man, I answered these questions already, why do I have to do these things again, and then be frustrated? No. Why? Because in ClinicTracker, when you click on co-triage and answer those questions, whether it's in person or by phone, all of those answers are stored in ASAM's central database. And when the patient is showing up at the next site, let's say now it's instead of a phone call, they're showing up at an outpatient clinic. The outpatient clinic will open up ClinicTracker, will open up Continuum, and we'll be able to see that this patient has already been assessed in the ASAM system under co-triage. And they'll be able to pull forward all of the answers that the patient already gave in that first 10-minute interview, you know, yesterday or this morning, and they'll be able to populate the new Continuum assessment with those exact answers because the questions are the same. And that way, when you, the interviewer, are talking to the patient, you'll be able to say, now I see when you did your co-triage interview with the intake person this morning or yesterday, you talked about problems with heroin and pills, and also you have some problems with alcohol, it appears. Is that right? And the patient's reaction will be, thank God these people talked. So you get to revise these answers if the patient says, yeah, I didn't tell you about my problems with methamphetamine. Okay, fine, we'll add that in now. But it allows the patient to feel that there is continuity in the process, which is what Continuum is all about. So we want to achieve what the research says is possible. And we want to reduce that no-show from, let's say, the telephone intake or the face-to-face intake to the recommended treatment. And what the research has shown is that you get, at a minimum, a 25% reduction in dropout or no-show rates right at the beginning. And it can be a dramatic reduction, like 1/3 of the rate of dropout, 300% reduction in not following through to the initial stage of treatment or next stage of treatment. Over time, let's say 3 months, you can reduce the rate of dropout by 30%. So if you could hold on to almost 1/3 more of your patients over the course of 3 months, that would be a huge improvement for the patient's benefit, for the morale of the providers, the counselors who get the longer term relationship with the patient, and for the milieu. And if you look at addiction severity composite score scales, at 3 months, you've got 3 times better improvement if the patient was assessed and placed with Continuum at the beginning than if they were mismatched. So it has a very profound effect to do a comprehensive, systematic approach. And it's not just in the numbers that you get this benefit, it's also in the patient experience. So when we assess patients all over the country, and I'm now talking about 6,000 counselors across the country, 250,000 assessments that have been done across the US in our database now. That's 250,000 assessments. And patients frequently say, wow, I'm tired. That's the most in-depth, longest, probing interview anybody's ever done when I've entered treatment. And then they say, and it's the best interview that's ever been done of me. So patients know they've really been thoroughly assessed. And what we believe happens, because the retention is so good, is that the patient feels like, well, that level of care they're recommending probably is the right thing for me to do, because they asked me questions about things I wasn't thinking about. They identified problems that I didn't even realize I had. And now that I realize I have all these problems, I think I need more care than I thought I needed. So I thought I was going to skip out with, I'll come back in a week and they'll give me some medicine. And instead, if they're telling me I need, intensive outpatient 3 times a week for 3 hours each time with group and individual, maybe that's really what I do need. And that has a motivational interviewing effect on the patient. So how does the tool really look on the screen? And why are 6,000 counselors all over the country in all kinds of states able to use this system? And it has a lot to do with how it was designed. And this took years to work out and considerable funding from SAMHSA. And then NIDA and NIAAA, the NIH, paid for a lot of this research. So it's taken many millions of dollars to get to this point. And when you log in and get to a patient assessment, you see 2 sides of the screen. On the left side is this dark blue background bar. And this panel is called the navigation panel. It has the name of the patient and all the categories of assessment that will be conducted. On this side of the screen, in the white background, is the interview panel with the actual questions and the options for different answers. The beauty of having a navigation panel is that I can see the sequence of questions in order. And when I'm starting out, I'll ask the questions in order. I'll just let the computer guide me. First, general information, then medical, then eventually we'll get to drugs and psych. Now, that follows the ASI, the Addiction Severity Index. And there's a logic to that, which is that it takes time in an interview for a patient to get comfortable and build a rapport with the interviewer. And as the interviewer is asking questions in a very friendly, sensitive, non-judgmental fashion, the patient gradually feels more comfortable and is willing to talk about increasingly more sensitive issues, more stigmatized issues. So often people will be happy to talk about their medical problems, their blood pressure, their asthma. And then when they see that this person is caring and is interested and is asking logical questions that the patient feels like, yeah, I'm glad they asked that question about my medicines. And then by the time you get through medical and employment issues, the patient is ready to start talking about their drug and alcohol problems. And then we can get into the legal stuff, which often is a consequence of those problems. So now the patient isn't saying, yeah, I have a big criminal history. They're saying, well, as you could probably understand, given my drug problems, I've got trouble with the law too. And finally, we get to psychological problems towards the end because those are the most stigmatizing. There are many people with addictions who feel like, yeah, my drug problems, they're really bad. I feel upset and guilty and shamed about those. But the worst thing is if people think I'm crazy. So this sequence has been evolved through years of research development. But what if you start interviewing the patient and say, tell me about your medical history? And they say, well, I got problems with my teeth and my heart, and it's all because of my meth use. And that's gone on for 5 years. And, I got to shooting it, and, then I got arrested. Well, now I'm getting all this information. The last thing I want to do, especially if I have experience, is I don't want to say to the patient, hold on, stop there. Now I need to ask you about your STDs. Because then the patient feels like, oh, so this isn't about my problems. This is about you and what you need to do. And now there's a barrier starting to come up between the patient and the interviewer. So we don't want that to happen. If the patient is productively, spontaneously telling you their story, we want you to do what you would do clinically, normally, if there wasn't a computer here, which is, all right, just tell me more about that. And what the computer navigation panel allows you to do is to skip around to these different sections and just plunk in answers to questions that the patient is already answering without you even having to ask them. So that freedom and flexibility improves the clinical feel of this experience and keeps it feeling like it's a clinical interaction, not a technology interaction. And as you go through, how do you know if you're getting all the answers and asking all the questions that still need to be done? Well, each section tells you how much is complete and how much more you have to do. So if you see some questions left unanswered at the end of a long interview, you can just go back in, click with your navigation panel to which sections. Oh, I missed some section in the psychological history. Click on there, and then I can say, oh, there's a few questions I didn't get to ask you. So I just want to make sure I've got everything. And then you can just ask the remaining few questions that need to be assessed. On the interview side, the questions that you'll see are laid out in a conversational tone. They're not like research questions if you've participated in research. There's a lot of fill in the blanks. And then when we train people to use their own language. The interviewer gets to paraphrase every single question. So if the question says, do you have any chronic medical problems that continue to interfere with your life? Well, if I already know that the patient has chronic medical problems because they told me about their arthritis and how much pain it causes, I don't need to ask the question in these words. I can say, now you told me about your arthritis, and I'm wondering, how is that pain affecting you? How does it affect, the stuff you like to do in your life? And now the patient is hearing a true spontaneous conversation instead of I'm reading off the screen. So continuum training will explain to use every question as a guide, and then to interpret the patient's answers as best you can. You never read all the options to the patient and then make them pick from them. You always ask the patient to explain what their answer is, and then you interpret if that's mild, moderate, considerable, or extremely. And often there are words to explain what each of those is. So you're truly using all your clinical skills, and the more expert you are as an interviewer, the better you can do this interview. But everyone will have the bottom line skill set of comprehensive, multidimensional, standardized interviewing. So this is how we have exceeded what research instruments have been able to accomplish. And that makes this a much more comfortable interview to use. And the more you use it, the more comfortable you get, and the more you get to use your own expertise and intuition. So at the end, you get reports. Now, the summary report has all the information you might need to provide to managed care. And it actually, in some jurisdictions, they actually fax the summary report to managed care to justify the placement. And it'll include like all the ASI composite scores, the CWA or CINA withdrawal scores, the DSM-5 substance use active diagnoses and recency of use, and whether withdrawal is an issue. Some of these have graphic representation, so I can see this patient still has some drug problems, not as much anymore, but the legal problems are really bad and the employment problems are really bad. and there's some lingering family and social problems. So we'll get information in the summary report that can be very useful for managed care. There's another report called the narrative report. And the narrative report reads like a biopsychosocial write-up. And it's divided into all these different sections. Here's the family social section. And it will be in English language. Now, it's generated by a computer. And we constantly improve the language of this, make it more personable. And so sometimes the sense, she has not had any significant problems with family members or friends in the past 30 days, but Samantha has not experienced any recent emotional, physical, or sexual abuse. So you'll see, there's some sort of readability that's built into this, but it's very organized. Obviously, it's legible because it's all in print. It's a PDF. And it will have a problem list at the end that can be the initiation of the treatment plan. In ClinicTracker, you'll actually have a button in the pull-down menu in demographics where actions allows you to pull down this option, ASAM Continuum assessments, and you click on that, and then you can, or you can do it from the patient contact records, pull-down menu, actions again. And when you do that, you can choose co-triage, which is the 10-minute version, 20 or so questions, or the full continuum assessment. And it'll ask you, you want to create a new comprehensive assessment? Yes, or add a triage assessment. So it's what you're used to seeing, just an additional set of options and no extra effort to log in. It should be very smooth. And all the data will be stored and then can be pulled back. Now, let's say you're reassessing the patient 3 months later after they've been in outpatient care, or you're transferring the patient, stepping down from inpatient to partial hospital or day treatment. When the patient arrives at the new site, if they're in the same system and in ClinicTracker, the interviewer can pull forward the last interview into a new interview. So all the data from, 2 weeks ago when they entered rehab can be pulled forward into the new IOP assessment. And all the questions that were answered before are now plunked in with the data. Now I only have to ask the patient questions that are likely to have changed since that first interview. So now my follow-up interview will be much shorter, maybe half the time. I will be able to learn how bad was the patient when they came in 2 weeks ago to inpatient. And now I can see by asking them, well, how is your withdrawal improved? Well, I don't need to ask about lifetime medical problems because in 2 weeks they probably haven't changed. So I'm going to skip that whole section and the data's already in there. Their psych stuff might have changed because maybe they started getting psych meds. So I might want to ask some questions about the problems they noted last time. Maybe their depression is starting to lift. Maybe their thinking, their thought processing is improving. So I'm not going to ask questions about lifetime legal problems because those were probably unchanged since 2 weeks ago. And having that ability to pull data forward into a new assessment repeatedly allows us to complete a new comprehensive assessment, but much more efficiently. So those are just some of the advantages of the system. I'll mention a couple more. Continuum helps even the most novice interviewer conduct a very good psychological symptom inventory through all the major categories of psychiatric disease: mood, anxiety, thought process, thought disorder, psychosis, even suicidal ideation, plan, and gesture. So, and capacity for safety. So the critical items, even in an expert suicidal assessment, are all available and sort of unavoidable, even for a novice interviewer. So I'm going to ask about suicidality with the critical questions: any risk of suicidal ideation, suicidal plan, urges, Has there been a history of suicidal gesture? And it goes further. For every psychological symptom and suicidal characteristic, it prompts the interviewer to then ask, if you've been having this in the last 24 hours or month, has this been in the context of getting high or using your substance? Or has it been when you've been coming down off of it, withdrawing from it? Or has it been independent of any substance use at all in your experience? And many patients will have a sense of that. And especially if you prompt them to think about it, they'll know, oh yeah, every time I'm coming off of my meth, I'm like suicidal. And they'll be able to say, and it's not like I would do anything, but I really wish, I dream about it, I think about it. And they'll be able to characterize the extent. So even novice interviewers will be able to do a very thorough interview, better than they would have otherwise. And that's the beauty of this. Now, Continuum will calculate how each of these answers, even in the suicidal assessment, predict the need for safety and intensiveness of treatment. Continuum will also calculate if the medical problems are kind of bad, but the motivation is good and the urge to relapse is moderate and often has been contained well by the patient. You combine across those dimensions, and maybe you don't need to be in a residential setting, but you might need partial hospital to really coordinate the medical workup and the follow-through and the consultations. So Continuum will calculate not just within each dimension how much service and intensity a patient needs, but across the dimensions. And it does that in a very reliable, consistent mathematical way. Although the interview itself can be a very clinical, natural, even warm interaction because you're using your own language skills. The interview is using their own cultural understanding of each patient. If the patient has limited English, you can simplify the words in the questions. If the patient has a gang background and needs to be asked about the legal stuff in a way that's comfortable for them or usual for them, you get to modify the language. And if the patient gives you a roundabout answer, you get to interpret which of these options is closest to what I heard from the patient. So you're still using your judgment and your own natural expertise. So even when you get a level of care recommendation at the end, you don't have to send the patient each time to exactly what Continuum recommends, because we trust clinicians to have judgment and we want them to still use that judgment. So you can say, I understand that ASAM is recommending this level of care, but the patient is really going to go to a different level of care. And then you get another question, which is, what's the justification for a discrepancy between where you're really sending the patient and where ASAM recommended? And you can say any one of a dozen different reasons. The patient refused. The program rejects the patient because they were there before and they started fights and beat up an aide and they won't accept them. Insurance won't cover this level of care for this patient, or the patient lacks insurance, or there's no geographic proximity of such a program, so we had to go to a different level of care. Even as the interviewer, I disagree with ASAM's recommendation. Now, we've had this happen many times, and we now have within Continuum an opportunity to send a message to ASAM that says, I need a help desk response because I didn't like this recommendation and I'm not sure why it came up. And right there, you can plunk in a request for a help desk assist. And ASAM receives those and analyzes them. We have a team of 6 scientists, including me, who analyze these requests. And we might figure out that, well, you didn't understand this question and the way you answered it put the patient into a level of care that wasn't right. Or ASAM actually thinks this patient should go to such and such level of care, and here's ASAM's rationale. It could even be that there's a problem with the computer or with the code or with the ASAM book, and we are actually revising the ASAM book into a 4th edition now that takes into account the many years of input we've had from interviewers in the field. So there is this feedback loop too. You or your staff will be using Continuum, but Continuum will be taking guidance from your staff too, to continue this process of continuous improvement. So I'll finish with that, and I hope we have some time for discussion or questions.
Thank you. I think we do have a question here from Jody. Let me see, Jody, if I can unmute you there.
Oh, I was just hoping to be able to write things in the chat. I was unable to do that, but I'm good. I don't have a question. This is very complete knowledge. Thank you.
Terrific. Are there any other questions out there? This is a great opportunity. Well, we have an outstanding resource here.
And thoughts and reactions, you know, is this something you knew about? Is this something that was new? Is it surprising? Is it confusing? How does it strike you? And don't be shy. This is just a discussion. And there's not too many of you to, you know, for everybody to have a chance to speak.
And if there are questions that, you know, when you bring this back, we'll share the recording. And when you bring this back to the rest of your team, and you've had a chance to digest a little bit, if you want to write in questions afterwards, I'm sure that we can get answers to those as well. Just taking a look here to see if we have anybody who has questions. And I think there are some questions, as I mentioned, regarding, you know, how to take advantage of this and how to integrate it into your clinic, which we can work with you individually and address. We'd love to help you with that. But if there are any other questions, again, well, we have the doctor here, that would be, now's the time to ask. Okay. It looks like you covered it so thoroughly that there are no questions at the moment. Oh, wait, I think I might have. Yep, lots of feedback that was very informative and covered very well. They were not aware, another comment that they were not aware, but it looks like a great tool that would assist the clinicians in many areas. So I think, oh, Faith, looks like, one second, Faith put her hand up. I'm going to unmute you, Faith, I think. Oh, I think you might be self-muted now. So if you, Faith, if you unmute yourself.
Okay. I just wanted to express appreciation for the webinar and to thank the doctor for the work he's doing on behalf of all of us in the field and for the people who are being helped. I just want to say thanks.
Well, we really appreciate that, Faith. You know, the science of assessment and predictive validity has been late in coming to our field. The utility of EHRs like ClinicTracker has been late in coming to the field, and in exploiting the power of the technology, that has been late in coming to our field. And it damages the reputation of the field. It's an opportunity to overcome stigma when we use technology to get better results and to be able to demonstrate those results. And you can imagine when patients go to a program where they get this depth of assessment and this clarity of treatment recommendations, they think that, wow, I didn't realize that addiction counseling programs got this stuff. Because people see it in their primary care doctor's office all the time. I mean, for 20 years, my doctor's been looking at a screen before she looks at me. And then she turns from the screen and talks to me. And then at the end, she talks to the screen again. And I know that she's not going to forget my allergies or, you know, my surgeries or whatever, because she's got all this support. Patients who come to a program that has this stuff realize, oh yeah, this program is modern. is up to this place is, really, got the right stuff. So it has a lot of qualitative value besides just the structure and the data.
Wonderful. Unless anyone has anything else, I think that's actually a perfect place to wrap up. Okay. I think that's it. Wonderful. Thank you so much for joining us. And of course, we appreciate the partnership. And as we close, those of you that have joined, if you have other questions or you'd like to see a one-on-one on how the integration works within ClinicTracker or how to turn on the feature, please let us know. Reach out to your account manager or through a support request. And we are very excited to try and help you put these tools to use. Thank you, everybody.
Thanks. Bye-bye.
Thanks. Take care.